Okay. Before it loads, I would like to thank the organizers for giving me the opportunity to talk about brain imaging, hybrid imaging of brain tumors. Also, I will show some PET-MR images. I will focus on the appropriate selection and analysis of the radiopharmaceuticals and relate that to MR findings, since I think this is of paramount importance to apply molecular imaging successfully into the clinical workup of brain tumors. What I will do is I will talk about glioma and will first about general aspects of it, then on potential radiotracers. I will cover FDG PET, amino acid analogues, and other radiopharmaceuticals. And at the end, I will talk briefly about meningioma and somatostatin analogues, since this gives an interesting link from imaging to therapy. The methods I will cover will be PET-CT, PET-MR, and a little bit of SPECT-CT, since this is important for theranostics. So let me briefly sum up about glioma. It is a most common brain tumor. It's approximately 80% of all primary brain tumors, and it has an incidence about 8 to 100. You can roughly separate low-grade and high-grade gliomas. So low-grade gliomas affect mainly younger patients and have a relatively good prognosis, whereas the high-grade gliomas have a very low median survival and mainly affect older patients. Within the gliomas, you can separate astrocytomas from the oligotumors, which have a separate genetic markup and a separate physiology and have also a better clinical outcome. So the range of the survival is very large, from the pilocytic astrocytoma and oligodendroglioma, which has a 5-year survival of 70%, compared to glioblastoma, which has a 5-year survival below 5%. So also I'm a non-radiologist. I would like just to give you my view on the MRI. This is a standard neuroimaging method in glioma, of course. It has a high sensitivity and excellent structural details. At least in our department, the workup includes a T2 flare imaging, where the tumor is hyperintense. You can see the perifocal edema and the mass effect. However, treatment-related changes are also hyperintense, like gliosis, leukencephalopathy, and necrosis. And you do T1-weighted sequences with contrast enhancement. Here the tumor is hyperintense. You can see with the contrast enhancement the blood-brain barrier disruption, which is suggestive for high-grade glioma. But approximately 30% of non-enhancing lesions, which would be considered by conventional criteria as low-grade glioma, turn out to be malignant glioma. So you have a limited specificity, especially after radiation and chemotherapy, and you have problems with the delineation of the viable tumor part. You have problems after therapy with pseudo-progression and pseudo-response, or later one, especially when you do anti-angiogenic therapy. And this is where molecular imaging comes into place. So how can we have such a big array of different radiopharmaceuticals? I will show you now in PET and not in MR and CT. And I think this is a nice indicative image just to illustrate that. So we are working with pico and to nanomolar concentrations of the radiopharmaceutical, which means you do not need to take care of the pharmacological properties of the pharmaceutical, but only on the radiation burden. And so this allows you, of course, compared to MR and to CT, a much wider array of imaging probes you potentially have. So here, if you look at oncological imaging, we have all kinds of physiological markers we could use. I would like to focus on all the probes which are in a red frame, starting with FDG, then labeled amino acids, then nucleosides, which do proliferation hypoxia markers, or markers which are indicative for an angiogenesis. Let's now start with FDG PET. So the FDG the up of the FDG PET is that it correlates with malignancy, since higher malignant tracers have a higher expression of the GLUT1 and GLUT3 transporters. So normally in low-grade glioma, the FDG is comparable to white matter uptake, and the more malignant it gets, the higher the uptake is. But here you see the problem in the practical use of FDG in this area. You see it's an WHO2 astrocytoma, but you cannot delineate it since you have the high FDG physiological uptake in the cortex, and you cannot see that. It is much easier if you have a malignant WHO grade 4 tumor where you have a high uptake and typically with a central hypermetabolism. The problem we have also with the clinical use of FDG is that it accumulates in inflammatory tissue and macrophages, so you have a difficult differentiation between glioma and acute or chronic inflammatory processes. So the main use, at least in Germany, for most centers which deal with brain tumors are labeled amino acids or amino acid analogues. You can use the natural amino acids, the C11 methionine. This has practical limitations if you use it clinically, since C11 has only a very short half-life of 20 minutes, and you have to do one synthesis and to image one patient, which is not cost-effective. The other ones are F18 labeled. The F18 has a half-life of around 2 hours, and this is much better to use clinically. And these two are, at least in Germany, commercially available, and I think fluorodopa is also relatively wide, the availability is relatively widespread. So why do we use amino acids? They have a key role for cell proliferation and extracellular matrix growth. They are substrates of the L-type amino acid transporter, and these transporters are highly expressed in primary brain tumors. And this overexpression is relatively well correlated with protein synthesis. Compared to the C11 methionine, the artificial amino acid analogues are not incorporated into proteins. This method is well established, and the reason why we use it and why the neurosurgeons demand it is that especially in recurrent tumors, like here in this study shown, and this is also our clinical experience, up to 50% of all cases we have changes in the management based on the finding of the amino acid PET if we combine it with the MRI findings. You can see that in our department we have approximately 700 investigations a year, and this is exclusively, the FET is exclusively brain tumor. So let me relate the FET PET with the MRI image. Here you see two cases where there is no contrast enhancement in the tumor. The tumor can be delineated in the T2 MRI, and the FET PET in the upper case shows a very high enhancement, and this turned to be outer glioblastoma multiforme, operatively confirmed. The bottom row is a low-grade glioma which has been confirmed by biopsy. In this case, in these two cases here, you see contrast enhancement in the rim of this operated lesion. And in the fusion image, in the case of the glioblastoma multiforme, you see on this rim a very high amino acid uptake, whereas in the case of the radiation necrosis, there is no relevant amino acid uptake. So which amino acids should be used? I think it depends clearly on the radiopharmacy, if you have an on-site cyclotron, and how you get the tracers. Since the diagnostic information, especially for static PET scans, is very well comparable, like you can see here in this study, where the methionine PET and the fluoethyltyrosine PET are correlated. If you correlate the fluorodopa and the fluoethyltyrosine, you can see that the extent of the uptake is more or less similar, but the intensity is somewhat lower in the F18 dopa PET. You have also an additional problem, since the fluorodopa is the precursor of the dopamine and surrogate marker for the dopamine storage capacity. You have physiologically a high uptake in the stratum, and this might hinder an exact delineation of the viable tumor if this is located in adjacent to the stratum. So what we can say is that it's clear you can use all the labeled amino acids, and you should use the one which provides you the best logistics. And the experience of the long-standing methionine PET can be extrapolated to the other amino acids. And we have a comparable sensitivity and specificity for tumor tissue detection, and the extension in the comparative studies of all three radiopharmaceuticals are similar. Fluorodopa has a disadvantage, since the striatal uptake might compromise tumor delineation, and also you need ideally pre-medication with carbidopa, what you do not need to do with the other tracers. But things which are good also have problems. So we have in the low-grade glioma with the amino acids only in about 75% of the cases positive tumor to non-tumor contrast. So we a substantial number of low-grade gliomas cannot be delineated by an amino acid PET alone, so you need, of course, the combination with EMR. In the high-grade gliomas, in approximately 100% of the cases, you have an increased uptake. And so because of that, a correct classification of low-grade gliomas versus non-tumorous lesion is a bit problematic. You have a sensitivity of only about 75%. You also have false positive results. Also, the number are low, but here are some examples. You can have that in acute ischemic stroke, here like in this case with a sinus thrombosis, and you have a subacute ischemic infarction. You can have that in some cases in a demyelinating process, or you can have that also if you have a very florid ZNS vasculitis. So this is something where you can be misled by the amino acid PET. Another problem of the amino acid PET is that compared to FDG, it's not so well suitable for grading. So the amino acid uptake only very weakly correlates with the histological grades. Also, high-grade gliomas tend to have a higher uptake. But also the oligotumors, which have a very good prognosis, have an extremely high uptake, and so this is not a prognostic marker. So on the individual level, you can see that here with this overlap with the FET, and also to some extent with the fluorodopa, conventional amino acid uptake does not allow grading on an individual level. But with an appropriate data analysis, you can do that. And what you have to do is a dynamic analysis if you use fluoethyltyrosine, since this yields a potential for the differentiation between low-grade and high-grade glioma. You have in low-grade glioma a continuous accumulation of this tracer in a similar fashion like you have in normal brain tissue, whereas in high-grade glioma you have a rapid increase and then the tracer is washed out. So the reason for that is not really well known what is causing that, but it helps very well to differentiate these two types. and this is independent of the absolute uptake. So we've looked at that in a relatively large cohort with a suspected low-grade glioma, and we've seen, if we look at the uptake, there's been no differentiation possible between the high-grade and the low-grade gliomas with conventional uptake parameters. But if we look at the kinetics, here two cases, two extreme cases, one grade 2 tumor with extremely high uptake but increased time activity curves, so the trapping of a tumor. Here, a glioblastoma multiforme with comparatively low uptake but a decrease in the kinetics. So with this approach, we have a much better sensitivity and specificity, especially sensitivity of 95% for the detection of high-grade tumors. We can also look for anaplastic foci in heterogeneous gliomas, and this is very important since these are the areas where you need to do the biopsy and they are determining the prognosis. What we've looked at is at grade 2 gliomas with a dynamic scan, and we have characterized three types of kinetics, so homogeneous low-grade kinetics, homogeneous high-grade kinetics, and heterogeneous kinetics, where we've identified areas with increased and decreased kinetics. So you do not need to do that painfully by region of interest now. We can do it on a voxel-wise basis, where the ones with the increased kinetics, you can appear red, and the other ones green, or you choose the color you want. And with this approach, we have a relatively good sensitivity and specificity and excellent positive predictive value in identifying these anaplastic tumors and guiding the biopsy so we can plan the further treatment for the patient. These dynamics are not only of academic values, they have a very good potential for predicting the cause of this disease, and you can use them for risk stratification. So if you have a histologically confirmed low-grade glioma which behaves according to the kinetics like a high-grade glioma, this presents an unfavorable disease course. So if you look at the progression-free survival, it's clear that the ones with a decreasing kinetics have a much worse outcome than the classical low-grade gliomas. This is also true for the time to malignization, and also true in a dramatic way for the overall survival. We can also work up and identify different prognostic subgroups in high-risk glioma. And we've here also looked in a relatively large cohort of patients with a primary diagnosis of high-grade glioma, almost evenly shared grade 3 and grade 4. And we looked with a multivariate analysis on the prognostic markers. And for the progression-free survival was, besides the promoter methylation, the time to peak in minutes. What is meant by that is if you have a tumor which peaks very early and has a very quick washout, this tumor has a worse prognosis. In a similar way, this was true for the overall survival. You can see here that in grade 4 tumors, this has yields no relevant information, but you can identify two subgroups in grade 3 gliomas which have a very different course of the disease. And we think that this kind of sophisticated analysis is a kind of next step to an individualized approach that we give this unfavorable subgroup a more aggressive, individualized therapy regime. The one problem for the operation is the exact delineation of the active tumor tissue. And can multimodal imaging contribute to an improved resection planning? There's limited data available, but the few data which are available states that the amino acid PET combined with MRI allows a clearer discrimination of the tumor boundary with a decreased remnant tumor mass and an improved post-surgical survival. Typically, it looks like that here. You see in the T2 image a much larger abnormal zone. Here, the contrast enhancement is smaller, and the amino acid PET is just between the two, which indicates that this might be the closest to the real viable tissue. So therapy monitoring is a biggest challenge in the workup and follow-up of brain tumor patients. Problem is especially the antivascular treatment, since you have a reduced vascular permeability and a reduction of contrast enhancement, and you can have the phenomenon of pseudo-regression without an effect in overall survival. And here, no radiographic modality has proven to be sensitive in monitoring these antivascular treatments' effects. This is not the case for spectroscopy. It's not the case for conventional and fusion reagent imaging MRI, but also, if one is honest, not in PET. So let me just show you one of these, such a patient illustrating the problem. Here we have a pseudo-regression after Avastin treatment. You see here the contrast enhancement is gone, and in the T2 weighted imaging, it also looks much better, but you still have an amino acid uptake, and after a very short time, you again see rapid progression of the tumor. Another problem we have are the contrast-enhancing lesion after radiochemotherapy, since we need to differentiate the tumor relapse to the treatment-induced changes. You can have a pseudo-progression which is characterized by early radiation-induced damage of neuronal and vascular tissue, and you have, on the long run, the radiation necrosis and subacute irreversible radiographic changes. So here we take advantage of the amino acids compared to FDG, since there is no significant uptake of amino acid tracers by glycolytic inflammatory cells. And we can differentiate these two situations, tumor recurrence versus radiation necrosis, which will look very similar in MRI, with a relatively good sensitivity and specificity, and a good positive predictive value. So FDG is here clearly not suitable, since you have a very inaccurate results, and 1/3 of the patients would receive here an inappropriate treatment. So what about PET-MR? Will this improve the workup of brain tumor imaging? These images I've got from Christian Lafougère from Tübingen, and he's looked at the spectroscopy with choline and compared that with methionine PET, and we could show in this area here of moderately increased amino acid uptake an increased choline peak, which is suggestive of increased metabolic activity, since the membrane turnover is here higher. This is a choline peak. You can also look at necrosis, which with MRS, which is characterized by an enhanced lipid in spectroscopy, and here in this case you have also very similar findings between the FET uptake and the lipid peak. But in some cases, you have very high discrepancies, which are not understood between these two markers of metabolic mapping. One would suspect that this comes up in a similar fashion, but this is, for instance, in this patient, clearly not the case. You have different areas of very high amino acid uptake, and other areas with almost no amino acid uptake, which are positive in the spectroscopy of choline. I think this needs to be understood and worked out. So we have clearly some complementary information here, but we have not understood the relevance of it yet. So in summary, the MRI remains essential in glioma management, but the use of amino acid PET permits a more specific tumor delineation. It's advantageous for biopsy planning, especially in gliomas without contrast enhancement. It's potentially useful for treatment planning of local therapies. It provides valuable information in the differential diagnosis between remnant tumor and post-therapeutic changements, in the assessment of early treatment response, in the risk stratification, and there are also some papers which have shown that this is cost-effective, especially for the guided surgery and for the diagnostic target selection. So in the ideal world, you would like to combine both methods with the PET MRI. So the advantages of simultaneous acquisition, in my opinion, are the one-stop shop. You have one investigation, one report with a combined interpretation, and one demonstration in the tumor board, which really enhances the acceptance and practicability. You, of course, have an exact co-registration. I think compared to other organs, this is in the brain less essential since this is a rigid body, and you can also do it with a software fusion. And you can, of course, do in one set and simultaneous assessments of the kinetics and the perfusion, DTI, and spectroscopy. And this all should result in an improved therapy planning, for instance, in the biopsy, the surgery, or the radiation therapy. So let me briefly talk about other radiopharmaceuticals. There are several markers of hypoxia. This is an interesting situation in the workup of brain tumors, since tumor hypoxia is related to structural and functional abnormality of tumor neovasculature. In the tumor expansion, you have an increased diffusion between distances between the vessels. So these are the reasons for the tumor hypoxia besides the anemia. And the tumor hypoxia is attributed a central role in tumor development, angiogenesis, and growth. And it results in resistance to treatment like radiation and photodynamic therapy, and also cytotoxic chemotherapy. And if you look at this, for instance, FF-meso, this is a tracer which is exclusively trapped in hypoxic cells. You see that this is mainly positive in high-grade glioma, glioblastoma multiforme, and grade 3 tumors, and not positive in low-grade tumor. It has the highest uptake in the border of the lesions, and it's almost exclusively correlated to the gadolinium enhancement of MRI. So this makes it, from my point of view, you see here this very tight correlation. This makes it, from my point of view, interesting for scientific studies, but it does not yield enough additional information in the clinical practice to really use it. And if you want to definitely assess the value of this, there are prospective studies needed to look at that for radiation treatment planning, where it would be most interesting, since the hypoxic areas are the ones which are not sensitive for the radiation treatment. Intriguing is also to look directly at proliferation. You can use the tracer FLT, the fluorothymidine, and you can see a very good positive correlation between the Ki-67 and the FLT uptake. But the main problem, again, for the practical use is that the FLT uptake depends on the blood-brain barrier integrity, and we are most interested in areas where that there is viable tumor and the blood-brain barrier is not yet disrupted. So this is very interesting, since you need to resect these areas to avoid recurrence. And you have also an increased FLT uptake only in a minority of low-grade gliomas. So this limited sensitivity makes it, from my point of view, inferior to the amino acid analogs. You can also look, and I think this is the way we will proceed in the future years, with specific tracers to select patients for appropriate treatment. So you can look, for instance, at the integrin A-beta-3 expression with galacto-RGD, or with this newer, a bit higher affinity tracer. At the moment, this is limited in its clinical practicability, since there is only a limited effect of this integrin inhibitors in glioblastoma multiforme compared to other tumors where it works well. And there's been no improvement in overall survival. But I think the principle is intriguing, that you use this kind of imaging to identify patients which would, in an optimal way, profit from such treatment, and exclude patients where you have, for instance, no high angiogenesis, which would not profit from this kind of treatment. And I think this is not very intriguing at the moment. This is, I think, the way we will use increasingly more specific radiopharmaceuticals. Let me briefly talk about the meningioma. This is the most common non-glial tumor of the brain. And over 90% of meningiomas are benign with low proliferation indices. And with a surgical resection, you get moderate long-term control rates. And so for this, you need then radiation therapy in the case of recurrence and unresectable tumors. Here, CT and MRI, also they are the primary imaging modality, have some limitations, especially in tumors with an infiltrative growth pattern in a skull base location and after repetitive surgery. Here you can use one thing which characterizes meningioma. This is that they have a high expression of the somatostatin subreceptor subtype 2, which can be imaged by a specific tracer, for instance, a DOTA conjugated analog DOTA-TATE. And you have, with that, a higher accuracy than just with contrast-enhanced MRI, especially for small lesion at the skull base and adjacent to the FARCs. And this helps in an enhanced tumor delineations for radiation therapy planning. I will show you an example. And using that, you have in approximately 2/3 of the patient a modification of the radiation field. It also has a potential for targeted therapy, which I will show you with a last slide. Here, one of our patients before radiation therapy planning. You can see very nicely here the extension of the tumor here in this 3D scan, and this small satellite lesion which was not readily visible in the CT scan and was overlooked. Here, one example from the Heidelberg group, which used it routinely for the radiation therapy planning and for a higher accuracy to assess a field, which is here especially important since this goes into the optical tract. You can also go for the next step, since you have this very high enhancement in these tumors, that you do not label these radiopharmaceuticals with a positron emitter, but with a beta emitter, and you can get relatively high radiation load to the tumors up to the order of magnitude of 100 to 200 grays, and it can, in this inoperable cause, which is also not possible to radiate in an appropriate manner, decrease the tumor growth and bring it to a halt. So this is a patient we've treated with 5 cycles of this ligand. We use this usually for neuroendocrine tumors, but it also works well for meningiomas. But we need to do here accurate dosimetry, and here is where the next hybrid imaging, the SPECT-CT, comes into play, since we need to assess here the radiation burden of the kidney compared to the metastasis. So this is another patient. This is, of course, not a glioma patient. This is a patient with a prostate cancer, but it illustrates the principle. So you need to do here, in contrast to radiation therapy with external beam radiation, an assessment of the critical organs, which are, since you do a systemic therapy, so you do not get a too high dose in that case for the kidney. So I hope I was able to give you a comprehensive review on brain tumor imaging, and thank you for your kind attention. I would like to acknowledge my colleagues, especially from the neurosurgery, and special thanks to Christian Lafougère, who helped me out with several slides, and to Natalie Jansen, who did most of the research work. Thank you very much for your attention.